Hello everyone, my name is Richard Shah, and today we'll be talking about diabetes. We'll be talking about screening and diagnosis. Some learning objectives: screening indications for diabetes, diagnostic testing, and how to interpret results. We screen patients based on indications set forth by the American Diabetes Association. Adults who are greater than or equal to 35 years old, any age adults with overweight or obese, and their BMI is greater than or equal to 25 or 23 if they're Asians, and with one additional risk factor. So these include first degree relative with diabetes, low HDL less than 35, or high triglycerides greater than 250, hypertension if they're on treatment, including physical inactivity, which I feel most of us are, and if they're of a certain racial ethnic group, including African Americans, Native Americans, Latino, Asian American, and Pacific Islander. If they have a history of cardiovascular disease, PCOS, history of gestational diabetes, or other conditions associated with insulin resistance, such as severe obesity, or if they have acanthosis nigricans. And if the results of the testing are normal, then we repeat screening at least every 3 years or sooner if they have symptoms or change in risk factors such as weight gain. And if patients are diagnosed with pre-diabetes, then these patients need to be screened annually. So what tests do we use to screen and diagnose diabetes? These include fasting plasma glucose, a 2-hour plasma glucose during an oral glucose tolerance test, and an A1C. So according to the American Diabetes Association, these are the diagnostic criteria for diabetes. And diagnosis requires 2 abnormal test results from either the same sample or in two separate blood test samples. And it's a positive test if the fasting plasma glucose is greater than or equal to 126, and they have to be fasting, that meaning they have to be fasting for at least 8 hours. A 2-hour plasma glucose during an oral glucose tolerance test of greater than 200. And this is performed by a glucose load containing 75 grams of glucose. You wait 2 hours and then you check the patient's glucose. And an A1C greater than 6.5. And also, it is also diagnostic in patients with classic symptoms of hypoglycemia or hypoglycemic crisis. So hypoglycemia symptoms include polydipsia or polyuria. And if they have a random plasma glucose of greater than or equal to 200 with a symptom of hypoglycemia, then that's diagnostic for diabetes. Using hemoglobin A1C has some caveats. And A1C itself can be affected by increased RBC turnover or decreased RBC turnover. Conditions that increase RBC turnover include sickle cell disease, G6PD deficiency, pregnancy, EPO therapy, and hemodialysis. And conditions that decrease RBC turnover include nutritional anemias such as iron deficiency anemia, B12, or folate, and also asplenia. So, for patients who have increased RBC turnover, the A1C underestimates glucose control. And for patients with decreased RBC turnover, the A1C overestimates the glucose control. This makes sense because, think about it, for patients with, let's say, sickle cell disease, they have the RBCs are constantly turnover, they have increased production rate and increased destruction. So the sugar in the blood doesn't really get that much time to stick to the RBC, and therefore the A1C measurement is actually lower than it's lower than it actually is supposed to be. So for patients with decreased RBC turnover, these RBC are staying in the blood a lot longer than they are supposed to, so it accumulates glucose over time, and therefore the A1C measurement will be higher than it actually is. Let's go over some next step questions. You can pause the video and fill these out before listening to the answers. In patients with A1C of 6.8, what do you do next? You will repeat the A1C or check a fasting plasma glucose. Remember, an A1C greater than or equal to 6.5 is a positive test, So therefore, for diagnosis of diabetes, you need a repeat A1C greater than or equal to 6.5 or a fasting plasma glucose greater than or equal to 126. So for patients with fasting plasma glucose of 130, what do you do next? Same thing. You repeat the fasting plasma glucose or check an A1C. For patients with A1C of 6.8 plus fasting plasma glucose of 130, what are the next steps? That is a diagnosis of diabetes because their A1C is greater than 6.5 and their fasting plasma glucose is greater than 126. What about in patients with increased thirst plus a random plasma glucose of 250? Well, that's a diagnosis of diabetes. Remember, going back to the criteria for diagnosis, if patient has symptoms of diabetes, increased thirstiness, and increased urination, with a random plasma glucose of greater than or equal to 200, that meets criteria for diagnosis of diabetes. And in patients for A1C of 6.8 plus a fasting plasma glucose of 110, what do you do next? You will repeat the A1C. In this case, the A1C is abnormal and the fasting plasma glucose is normal, so you will repeat the abnormal test. For patients with A1C 6.0 and fasting plasma glucose is 130, what do you do next? You repeat the fasting plasma glucose, because again here, the abnormal test is the fasting plasma glucose. For patients with A1C of 5 plus a fasting plasma glucose of 180, what do you do next? Here we consider an increased RBC turnover. If you look at the A1C, it's 5 and fasting plasma glucose of 180, there's a discrepancy here. Normally in patients without diabetes or pre-diabetes, the fasting plasma glucose should be less than 99. So the fasting plasma glucose here is likely correct and the A1C here is likely an underestimation. So you will consider conditions that cause that, and these are conditions that increases RBC turnover. So here you will actually repeat a fasting plasma glucose. And if it's still abnormal, then you have a diagnosis of diabetes. So in summary, we spoke about screening indications for diabetes, and these screening tests include an A1C, fasting plasma glucose, and if it's a positive test, that must be confirmed with repeat testing. And if the test is normal, you will repeat every 3 years. And if you find a patient with pre-diabetes, you will repeat it annually. And A1C is affected by increased or decreased RBC turnover. Fasting plasma glucose and 2-hour oral glucose tolerance tests are not affected by RBC turnover. Thank you for listening, everyone. If you thought this video was helpful, please like, subscribe, and look out for my next video.